Cool. So thanks for coming out, guys. This is going to be actually really fun. I think we've planned a few different things, including a suture workshop with the Army. How many of you guys know how to suture? Oh, okay, a bunch of people. Nice. That's always fun. Bananas or whatever else the Army's going to bring. They're going to be here, I think, in a little bit. I'm going to be talking, I'm going to give you two talks today. One about being a pre-med and what it's going to take. The other one about medicine and the future of medicine. I think both are going to be super helpful for you guys. And then we have Global Medical Brigades here as well, talking a little bit about international experiences, how you guys can get them. I think the whole goal of today is hopefully just for you guys to be exposed, boost your application a little bit, learn some skills, learn a few things that hopefully will help you. So why don't I get started with actually just figuring out who you guys are, which I guess the question I will start with is how many of you guys are pre-med, not other pre-allied health in here? All right, cool. We got the right audience. Sweet. All right, so most of you guys here are pre-med, which is great. And show of hands, first years. Okay, a lot of freshmen in here, sophomores, juniors, seniors, fifth years, sixth years, seventh years, red shirts, whatever else. Cool. So we got a ton of people in here. This is gonna be good for really everybody. And thanks for Shakib FAMSA for hosting us and allowing us to be here. So, what I want to talk about in the first talk is basically everything you need to know about being a pre-med. Some of you guys will know more about UT Austin certainly than I will, and so I'll lean on maybe some of the seniors to give some insight into being a pre-med here. I'm going to talk more generally about maybe what it takes, and then also how it's changing, right? A few things that are definitely changing in admissions, in being a pre-med. For you guys who are freshmen, things may look very different in 4 or 5 years, and I'll talk about why that is. Before I talk about that, I mean, you guys have all sort of self-chosen and said, I want to be a doctor, which is super cool. Obviously, at some point in my undergrad career, I did the same thing. And I said, yeah, this is what I want to do. And I'm an interventional radiologist. And so I wanted to give you just a quick glance into some of the things that I do, or why I'm excited about it, and why I think you guys are making the right choice by going into medicine. Does anybody here know what an interventional radiologist is? Yeah. What do you got? Give me a description.
Radiology side of things is you interpret anything with a scan at the end, MRI, PET scans, CTs, all that stuff for helping diagnosis. And then if need be, probably do interventional stuff with contrast fluid.
Yeah, that's a decent definition, pretty good. There's certain, most people probably know the field of radiology, right? Interpreting scans, looking at CTs, MRIs, X-rays, et cetera, trying to help diagnose what's going on. The interventionalist side is actually a split off of that, and it's much more akin to minimally invasive surgery. So basically what I do is I use imaging to perform minimally invasive surgeries that maybe 10, 15, 20 years ago needed to be big open surgeries, and we can do that now minimally invasively. And by the way, the second talk is all about sort of the history of medicine and where we're going, where we are today and where we're going, and I'll get more into that when we get there. But let me give you just a glance. This is actually my favorite slide about interventional radiology, right? It's like surgery, but actually it's magical. It really is. And let me give you a little bit of why, right? So I got a patient who comes in, 46-year-old, coughing up blood. For all you guys who have taken anatomy or more advanced physiology classes, does anybody know what this is called? Coughing up blood, what's the medical term? Anybody? Anybody in EMT? You get a free stress ball if you know. Hematemesis, all right? So hematemesis is coughing up blood. That's the medical term. So somebody comes in with massive hematemesis, that is a medical emergency, right? This person's coughing up a ton of blood, and there's a bunch of reasons for that. But one of the more common reasons is something called cirrhosis and portal hypertension. You guys heard of cirrhosis, right? Everybody probably knows what that is. Do you know what portal hypertension is? Anybody have a educated guess as portal hypertension, what that might be? Anybody? Yeah.
High blood pressure in the portal.
Say again?
High blood pressure in the portal.
So high blood pressure in the portal system, in the portal vein, is portal hypertension, right? Hypertension otherwise is high blood pressure in your body. Portal hypertension is high blood pressure in the portal system. How many of you guys have taken anatomy or bio? Probably everybody, right? You guys know the difference between the portal circulation and the systemic circulation? So the systemic circulation, right, is your arteries and your veins, right? So heart pumps blood, takes through the aorta to all the arteries, and then it comes back via the veins, right? But there's actually a third circulatory system in the body called the portal system, and that's all about your gut. So your liver and your bowel have sort of a separate circulatory system. Why? Because what's your liver's job in the body, broadly speaking? Filtering, cool, right? So the liver's job is to filter out toxins, right? So you eat shit, and then the liver's got to filter it out, right? You're eating a bunch of crap every single day that we have to eventually filter out. Eventually some of that gets pooped out, but you have to filter out the toxins, ammonia and everything else, in order for your body and your blood to work. So this is what a normal blood cell does, right? So a normal blood cell is going through the inferior mesenteric vein, up the portal vein, liver filters it out, and then it goes up the hepatic vein into the heart, right? So right above the hepatic vein is the heart. And then that's going to be pumped to the rest of the body from there. And so that's normal. But what happens when you have cirrhosis? Well, cirrhosis is your liver is hardened, right? You've been drinking too much alcohol. You have fatty steatosis. These are things that eventually harden the liver. And what happens there is that the blood can't take that normal pathway. So it goes up, and then all of a sudden, the liver shoots it back out because there's too much hypertension there, right? The liver is essentially too hard for that blood to filter through. And so where does that blood go to? Well, it's got to get back to your heart somehow, right? You can't just be hanging on to blood. It's got to be a circulatory system. And what it does is it goes through these pathways, which are called varices, which were alive when you guys were babies or in utero, but have closed down since then, but open back up in a patient with cirrhosis. And so these things open back up, right? And they can be umbilical. So if you ever looked at a patient with cirrhosis and looked at their belly, you see all these little veins. It's called caput medusa because their umbilical vein has opened back up. Or it can be coronary veins, or it can be short gastric veins. And these are all things that can eventually bleed because they're not really supposed to be pressurized, right? They were supposed to have been closed down the minute you sort of got out of utero. But now they've opened back up, and then they start bleeding, and they can start bleeding into the stomach, into the esophagus, and that's how you cough up blood, right? So you have these varices, and this is a medical emergency, right? This is somebody who is going to die. And so what can we offer this patient? Well, they might come into the emergency room, and the medicine team and the emergency docs down there can fluid resuscitate the patient, right? They can give them blood, they can start IVs, they can start pumping blood into them. They can start drugs for pressure support, right? If their blood pressure is crashing, we got to get their blood pressure back up because if not, there's not enough perfusion to the brain. That's a problem. The GI team might be able to place a Blakemore tube. This is something where you actually literally blow up a balloon in the stomach to stop the bleeding temporarily, but you can't live with a balloon in your stomach forever. And then, long term, you might have to literally take out this liver and put in a new one, right? But you can't do that when somebody is acutely coughing up blood. And so this is where interventional radiology comes in. And what we do is, I could create a whole new pathway for this blood to flow through in the emergency setting. And I'll do this by sticking a really long needle from the neck into the liver and into the portal system and essentially putting a stent in, and now I can bypass the blockage. And then at the end, I'll put a Band-Aid on your neck and you'll walk away. Now, when I learned about this in med school, my mind was blown. I was like, what did we just talk about? We just talked about creating a whole new pathway for blood, and I'm going to put a Band-Aid on, and that's it? I mean, I don't know if you guys still do Chuck Norris references, but to me, this was like Chuck Norris shit, right? This is like, wow, how did that just happen? And so let me take you through this a little bit more in detail. This is, I would be doing this at the neck of the patient under fluoroscopy, so under x-ray, but this is actually what's happening inside the patient at any given time. So I would be threading, I don't know if that's playing, but I would be threading essentially a wire through the neck, down through the heart, into the hepatic vein. There's the hepatic vein. And then I would take a really long needle, right? And keep in mind, I'm doing this all blind. I'm doing this all with X-ray. Can't see what's actually going on. But I take this really long needle, and then I'm able to stick into where I think the portal vein might be. And I know that based on anatomical references and landmarks. And so I stick this long needle into the portal vein. Remember, that's where blood is coming from, right, from the gut. Eventually, I put a wire down that, and then I can essentially create a new tract right there. So now blood does not have to go through the liver. It can go straight from the portal vein up to the hepatic vein into the heart, right? So it's bypassing. You see all that other stuff on the other side there, the little squiggly purple? Those are the varices, right? That's what's bleeding. And so eventually, here's the balloon coming down. You could put a balloon in, make a little tract, and now blood has a new pathway to flow through, right? A completely new pathway, and I'll put a stent there at the end, essentially to keep the blood flowing through the liver, totally new pathway, right? It's bypassing what's blocked, and so it's plumbing, right? It's like, you know, we created a new pathway for this thing to go through. Now, all of a sudden, this patient is no longer feeding those varices. Blood is no longer going through those varices. Blood is going directly back into the heart, the way it should be, and not into the varices. So when I learned about this in med school, I was like, as I said, I was blown away. And I said, yeah, that's what I want to do. And this is one of the many procedures I do on sort of a daily basis. And I bring this up because I think this is, I think this is pretty cool, right? This is, by the way, what it looks like when I'm doing it. So I'm watching fluoroscopy while I'm doing this. And so I don't see the actual liver. I just know where I am and where if I inject contrast dye, I can see the veins or the arteries or the portal vein or whatever I'm injecting to understand where I am. And this is sort of what it looks like. You can see that big thing, the big black thing, those are the varices, right? So you can imagine blood is flowing up those where it's not supposed to be, and now it's bleeding into the stomach or the esophagus. And once we put that tip stent in, and you see a bunch of metal that you don't actually see it, it's sort of subtracted out, but once we're done, blood is no longer flowing up that pathway, and so the patient is no longer bleeding, right? Blood is now flowing back through the liver into the heart. So again, the reason I bring this up is because I think what you guys are about to embark on is super cool, right? Medicine is at the end of the day really awesome. And interventional radiology is just one of hundreds of fields in medicine. Some of you guys may be bored by this, but may be really interested in mental health or pediatrics or anything else. Every single specialty has its own really unique, fun things that you guys are going to be embarking on, right? But it's a long-ass process, right? For you guys who are freshmen right now, we're talking about 8 years at minimum before you graduate med school, probably more like 10, gap years, everything else. Then 3 years of residency, many years of fellowship, right? And Hippocrates, the father of medicine, sort of, life is short, art is long, right? The art of medicine takes forever to truly master, or you never actually master it, you're always learning. It takes a long time. And guess what? Life is short, so you got to be in for it, right? It's going to be a lot of your life of the next few years that are going to be dedicated to this. And this is just something that I caution, is that we still don't know anything, right? And this is what my second talk is going to be all about, which is why, how cool medicine is today and where it's going to go. You all in this room are going to do crazy things that I would never have thought about, that 10 years ago somebody in this same spot would have never thought about. All right, so you guys know you're in college. A lot of you guys have to do post-bacs, gap years, then medical school, right? Then you do internship, then you do residency, then fellowship, and then finally you become an attending. So we're talking, again, 10, 15, 20 years from where you guys are to hopefully getting to where you want to be, right? But you shouldn't be afraid of that. You should be excited by it because there's a lot that goes into it. Now, the problem, and this is where I'm going to get into, hey, why is it so hard to get into med school these days, right? Is there's a big weed out that happens, right, along the way. A lot of you guys who are seniors probably had a whole bunch more people who were in the freshman class who said they were pre-med and then didn't end up finishing it out, right? For every 10 people who start medical school and start college and say, I'm a pre-med, probably about 1 or 2 of them actually end up in med school, right? So that kind of sucks because look around, all you freshmen, there might only be 10% of you that eventually make it, but if you listen to this talk, you'll all get there, right? Obviously, there's orgo, there's going to the MCAT, then there's the actual application. All these things are tough, right? And it ends up being that, you know, the average acceptance rate to US med schools is around 40%. And that's, again, if you finish orgo, if you finish the MCAT and everything else. And you guys probably know in the last couple of years, this has become even more competitive, right? We had about a 20% increase in applicants about 2 years ago. But the number of seats on that other chart really doesn't move, right? It goes up like 1%, 2% a year. All of a sudden, you have 20% more applicants, though. The interesting thing, and this is AMC data, is that the average MCAT and GPA really didn't budge much, right? And so you would think, okay, it's really more competitive, but it's not the MCAT and GPA. That's a part of it, but it's everything else that you do, and that's actually what this day is sort of a part of, which is, hey, what else can you say? What else can you say you've done? Oh, I did suture workshops. I learned how to do that. I know how to suture. I was an EMT. I went abroad, right? All these things actually make a huge difference in the med school admissions process. So the things that you're going to need, right? I just break this down simply, right? You need brains, you need a good GPA, and you need a good MCAT score. That's obvious. But you got to have the heart to do medicine. You got to have the lungs to breathe through this entire process, right? And then along the way, there's going to be a ton of failures. You're going to have a bad grade. You're going to, do poorly on your first MCAT. It's part of the deal. Don't worry about it. As long as you sort of know that you can filter out these failures and keep going, you're going to be fine. Now, for those of you guys who said, hey, I want to go into medicine, I just want to make sure you ask the right questions, right? It's easy to say, well, I want to go into medicine because I saw it on TV, or my brother did, or my parents are doctors. But those aren't good reasons, obviously, right? So ask yourself, have you shadowed? Are you saying this because it's a lucrative career? Because it's not, by the way. Are your parents doctors? If that's your reason, not a good reason. Let's figure out another one. Have you explored other careers before deciding on that? And if you're not sure about any of these things, that's totally fine, but let's help you figure that out. Another quick plug for why medicine is pretty cool. It's so diverse, right? There's so many things in life where you can say, okay, I'm going to go be a lawyer and specialize in one area, or I'm going to go be an engineer, and then you could change your career within those fields pretty easily. But at the end of the day, an engineer is doing pretty much the same job as another engineer. Not exactly by any means whatsoever. There's obviously differences. But in medicine, I think those differences are really, really vast, right? The daily life of a neurosurgeon compared to a psychiatrist is completely 180 degrees different, completely different. And so you guys may say, well, I want to go into medicine, but unless you really understand the different specialties in the different fields, it's like too vague to just say that. You got to figure out a little bit more about, hey, what are the parts about medicine that I like? Is it the patient interaction? Is it the cool technology? What is it, right? Is it being a part of groundbreaking cancer therapies? There's a lot of things that you can think of there. Has anybody ever seen this slide? Or everybody ever seen this? This is basically why you don't go into medicine to make money, because you won't make enough at the end of the day, trust me, for the stuff you're putting in. So this is a comparison of a UPS driver working full-time, a UPS driver working doctor-like hours, and then a doctor, and the years after high school and what their cumulative wealth might be. And the red line is the doctor, right? You're paying for college, you're paying for med school, you're going in debt, you're making 30 to 40 grand as a resident for the next 7, 8, 10 years before you finally get to the point where you're making money. So it's a long way off, right? And of course, eventually you can catch up and you will do totally fine. You're always going to be comfortable as a physician. But you should never do this for the money because there's a lot better things to go into if you just want money. Just want to throw that as an aside. You know, your pre-med life is filled with debt. Thankfully, you guys are at a great state school. Hopefully, you're taking advantage of good tuition rates. And you won't have to graduate with a ton of loans, but obviously a lot of people do. You're going to have to apply to med school. You have to pay for the MCAT and all these things, right? And so these are all the things that I would warn to discourage you But remember what I said at the onset of this, right? It's all worth it at the end of the day if you like what you're doing. So what's it going to take, right? What's it actually going to take for you guys to get to where you need to be? Let's talk about that. This is what some of you guys might look like. Sometimes I give this talk to parents and they're like, holy F, like I don't want my kid to go into $300K of debt before they start making any money. And this is what the parents often look like. Some of you guys might look like this. But what I would say is relax, you'll get there. This is your present day self. There's a couple of things you got to do to layer yourself to be competitive, right? Good grades, good MCAT score, extracurriculars. The something extra is super important, right? What is that extra thing that you're going to have compared to the person next to you or the person at UT Southwestern or wherever else you're going to compete up against? And then, of course, the applications and interviews. I don't know if you guys know this, but UT Austin is the second most popular pre-med school in the country. Congratulations. In fact, this is probably actually less than accurate because this is AMC data, and a lot of you guys obviously are from Texas, and so it doesn't account for TMDSAS, which is the Texas application. But at the end of the day, you are surrounded by more pre-meds than pretty much anywhere else in the country. That's a great thing because it gives you a ton of opportunities like this. It's also kind of a crappy thing because you're competing up against each other at the end of the day in some way at least. Now, I'm not saying be competitive. In fact, be the opposite of competitive. But there's a curve that every class is graded on, and you guys are all aiming for sort of, similar things, and it becomes sometimes a little bit tougher. This chart, I think, is nice to just think about for a sec, which basically goes into all the GPAs that somebody could apply with, all the MCAT scores that somebody could apply with, and puts it into, okay, how many applicants were there? How many acceptances were there? And the things I want you to think about here are, look all the way to the top right, where it says greater than 517 MCAT score and greater than 3.79 GPA. And you have 9,726 acceptances of 11,692 students. For most people, if I would say, hey, you graduated with a 3.85 and a 520 on your MCAT, we would take that and run, right? And be like, hell yeah, I did really well. Even that, only 80% of students who had those grades got in, right? So there's something else that you have to do. There's a lot extra that you have to do. And I'm going to talk a little bit about how I think this might be changing too in the next couple of years. This is a little bit more detail on the numbers, right? So this is the average applicant. Average applicant has about a 507 MCAT score, 3.5 GPA, or 3.7 non-science GPA, 3.6 total GPA. And then this is the average accepted student. 512 MCAT, 3.7 GPA, 3.8 science GPA, or non-science GPA, sorry. So these are numbers to keep in mind, right? Most people applying right at the 50th percentile, around that 507 MCAT score, but the people who are getting in, more like a 512. But let's talk about how this may be changing a little bit. You guys all have heard of the US News rankings. Have you guys been following what's been going on in terms of schools pulling out of the US News rankings? Hopefully you have, because it's a good thing. US News is not a news magazine, it's a BS magazine that literally just tries to sell more copies of itself by ranking everything and exploiting sort of the human nature or the human want to rank things. And they end up ranking medical schools, undergrads, cars, shoes, I don't know what else they rank, but they rank medical schools as one of the things. And it is a crappy system, right? Medical schools shouldn't be ranked like that. It shouldn't make any difference to you where you go to medical school, as long as you're in a US medical school. An accredited US MD school is amazing to get into. And so now as medical schools are saying, you know what, we agree these rankings are not really that important, and they finally followed some of the law schools who did this back in the last fall, that's going to change the way that they think about accepting an applicant. Because the way that they currently think about accepting an applicant, or they did think about accepting an applicant, was very much, hey, we got to get our average MCAT score up. We got to get our average GPA up, because those things are big factors in the US News rankings. And this is actual conversations that happen at the board level, at the admissions committee level, where it's like, hey, our school has dropped too far in the rankings. We need to get back up. These are the conversations that were happening, but hopefully now they're not going to happen as much, right? So does that mean that MCAT might not be as important? Does that mean that GPA might not be as important? Hopefully, because it means that all the other things that you do will hopefully be more important. I throw Harvard and Columbia on there because these are my schools. You know, Columbia just yesterday, this is undergrad, but they announced that their undergrad policy is now completely test optional for the SAT. They do not require the SAT at all for admission. They're the first sort of Ivy or bigger school to say that completely, and that's huge, right? So what happens to the MCAT 3 years from now? Well, if SAT is not required for high school, is MCAT not going to be required for medical school? Maybe, right? Or maybe it's going to be required, but there's going to be less emphasis on it. Those are all potentially good things, but then it does mean that you have to separate yourself some other way, right? So now a 520 MCAT might not mean as much. You got to think about other ways to separate yourself. And that's really with the kick butt extracurriculars, right? So when I sit down and review an application for admissions committee, I'm really looking at, well, what has this person done, right? Have they shown me longitudinal experience? Do they have leadership roles, original ideas, or things that they've brought to the table, or are they just sort of funneling and filtering what everybody else did? Do they have some international work? Maybe that could be interesting. These are all the things that I think are going to become even more important in the next couple of years as you guys go down this pathway, right? So the pillars of extracurriculars, right? Shadowing, volunteer, leadership, research, clinical. These are sort of the pillars that anybody will tell you about. And let's talk a little bit about how many hours you need, because this is such a popular question I get. I work with hundreds of students a year, and they're always like, how many hours of this do I need? And one thing I'll caveat all these slides with is that use these only as a general reference point, right? Nobody should think that they have to sit there and do 100 hours of anything and just check a box. That's the worst thing that you could do for a med school application. But keep in mind, you're competing up against other people, and so as long as you should be showing us that you have at least a foundational experience with all these things, leadership, shadowing, clinical research, et cetera, to be a competitive applicant, right? So volunteering, typically what I would say is, I want you to have at least 100 hours in your college career, right? And by the way, applicants that maybe have done one singular experience more in depth might be a better story, because it's about how you craft your application, how you write your personal statement, what your theme is. That might be a lot better than doing 1,000 different things over the course of 4 years. So if you start a chapter, if you really dive deep into something, that's what's going to be really important. Shadowing, you guys have all heard that shadowing is important. You guys also all probably are like, it's hard to get shadowing experience, right? HIPAA, COVID, all these things have made it even harder. But we want you to have at least 3 different physicians and 3 different specialties, so that when you go sit down for that interview, you can actually talk about this, right? You can talk intelligently about the fact that, hey, maybe you saw an emergency med doc, maybe you saw an IR, maybe you saw a surgery, maybe you saw an oncologist, and you could talk and say, you know, that one time I saw an oncologist, it was a great experience. I got to really understand how physicians deliver bad news, right? Whatever it might be. These are going to be important when it comes time for your interview. Now, as you guys are thinking about getting the shadowing experience, I want you to think about, before you shadow any physician, to have a baseline of what that physician does, okay? That's actually super important, because I get shadowing requests all the time. Students come to me, and some of them have read up, and some of them have some idea of what's going on, and others don't. You're obviously not going to know everything about a specialty by any means whatsoever, but if you can have a basic understanding, you can have a much better rapport with that doctor, and you're going to have a much better experience. And so, you know, one thing that we do at MedSchoolCoach is we have this Beyond Shadowing of virtual clinical education, where we have about 20 or 30 specialties. We've sat down with physicians and actually just recorded, like, hey, tell me a basic case. Tell me what you do on a daily basis. And before you go shadow any physician, I want you to just sit down and do this. Take the hour, watch the video, because it'll go a very long way in making your shadowing experience a lot more fruitful. If you're just a fly on the wall and you don't understand what's going on, that's no good. It's not going to get out of it what you need to get out of it, which is, again, the experience to talk about this on a med school application. And now clinical work, right? So shadowing was great, but we want you to do more. And a lot of that more is direct patient work, right? So I want you actually to have talked to a patient, to have taken their vital signs, to have worked as an EMT, to have gone abroad on a brigade, to actually have interacted with patients. Because if you haven't done this, you don't really know what it's like to potentially do in the future. And this becomes super important, right? I throw out a guideline of 50 to 100 hours. Again, these are all just guidelines. Nobody should take this as like exactly what you need to do. But if you look at the average applicant, this is sort of what they end up at least having to be competitive. Research experience, incredibly important. At least some sort of research, right? That doesn't mean you have to spend all your time in a basic research lab. It doesn't mean you have to publish a paper necessarily. But if you can show us, hey, I have what it takes, or I've done at least some scientific inquiry, it's important. And if you could show that you've done a lot of it, actually goes a really long way, right? So if you can get into a lab, or you guys are interested in it, or there's clinical research opportunities that are interesting to you, take them. And don't just take them for the research, but talk to your PI a couple of weeks in and be like, hey, I want to present this somewhere. Where can I present this? There's nothing but conferences all over the country. You can go present it at some conference somewhere. That little presentation that you make goes a long, long way for an actual application, right? Again, you could talk about it really intelligently on your interviews, and when admissions committees sit down and look, they say, hey, this person presented 3 papers at Astro. They didn't have to publish anything, but they at least presented something. You know, that's a really big deal. And then leadership experience, right? And so I implore all of you in this room to find opportunities where you're not just part of a group, but you're leading a group, right? You're on the e-board, you're doing something more. Think about the way physicians in a hospital interact, right? They are the head of the ship, they're the leaders. They might be running the code. They might be the one ultimately responsible for during the surgery, where they might be making the final decision on what medication gets administered. That's all leadership, and that's why we want to see leadership in our applicants when we sit down on committees. Let me stop there for a sec. Maybe you have any questions on sort of activities? If not, we'll move on to the MCAT, and we can definitely go back to questions at the end. Let me talk a little bit about the MCAT. How many of you guys have taken the MCAT so far? Okay, how many of you guys are registered for an MCAT soon? Okay, a bunch of you guys, good luck. And the rest of you guys eventually will take the MCAT in a couple of months to years. As much as I said, SAT is test optional, I don't think the MCAT is going to be test optional within the next 3 years. I think it's going to take a longer amount of time for that to actually perpetuate and happen. So unfortunately, all of you guys are going to have to take the MCAT at some point. Probably know MCAT is scored on a bell curve, right? Top of the curve is 500. That's the average. Remember, the average applicant had more like a 506, and the average accepted student had more like a 512. This is what your score report looks like. You're going to have like palpitations waiting to open this email and go on to AMC when you get your score back. And hopefully it's a great score, right? But even if it's not, don't worry. I can tell you my MCAT score actually was not that good, but I still cracked into a bunch of really top schools because of the way that sort of you portray yourself, the way you put together your application, everything else. MCAT is not the be-all and end-all, but it is super important. You got to get to a certain point for schools to consider you appropriately. And so I'll just very briefly talk about dealing with the MCAT. Just a couple of things to keep in mind, right? Your best preparation is going to be your pre-med classes, right? So you guys are all taking bio, orgo, chem, physics, etc. Even if your teachers suck, your teachers might be great, I don't know, but their sort of curriculum and what you learn there is going to be your best preparation, for sure, right? Having that solid foundation is huge. And so as you're going through your pre-med classes and studying for your bio test, right, you are still studying for your MCAT. And so if you have a good foundation there, the time you go back to actually study for the MCAT is going to be so much better. I would consider passive studying early, right? What's passive studying? Audio learning, I think, is huge. If you guys are podcast listeners, subscribe to MCAT Basics. It's huge. It's free. Just sit there, you listen to it, you're at the gym, whatever else. It will ingrain in you after a while whatever it has to ingrain in you. You could start doing this as early as now because you will listen and you will hear and it'll come back to you when the comes time to study or when you're reading that passage. So I'd really recommend that. You need at least 6 weeks off, right? You need at least 6 weeks to study, I would say, if you're typically off. Or you should consider studying for about 3 months or so, or set your study schedule for that if you guys are also in the middle of tests, exams, and classes and anything else. It doesn't mean you're studying 24 hours a day for 3 months, but what it does mean is that you have a schedule laid out for those 3 months that you're going to follow and get to. AMC questions, that's the maker of the test, right? Super important. Other practice exams are critical. Always do practice exams. Always learn as you're doing those practice exams. And then consider the big box classes sort of carefully. They might work for some people, but they don't work for everybody, right? Think about what's your weakness, right? You may be a bio major and you may be great at bio, but you may stink at cars. Well, if the exact same amount of time is being spent in bio and cars, that might not be great for you, right? So a little plug for some of the stuff that we do is we really try to personalize this. For you guys who are early or late, our MCAT prep app is truly awesome. You guys should download this. You should study with it as you're going through the years. It's like $20 a month as opposed to about $4,000 for one of the big classes. So I think it's a really good value. And it's got flashcards, videos, questions. It'll just help you as you go. So there's a couple of plugs I'm going to make. This is definitely one of them. It's a great, great, great app. And then I talked about MCAT Basics, which is our free podcast. But for those of you guys who are closer to the MCAT, maybe 3 months or 6 months or less, we have actually an audio learning course, which is super, super helpful. And it really helps you retain the material a ton better. And just keep in mind, we have a little coupon for you guys, UT Austin. It'll be 30% off forever. So these are two things that I would highly recommend you use. Now, who's actually in the application process this year? Maybe actually in the application or going to be in the application process this summer? Okay, so a bunch of you guys are going to start the application process this summer. And let me just give you a timeline. This is helpful for all the freshmen too, just to give you an understanding of what this timeline looks like, right? So in January to April of a given year, you might be taking the MCAT, right? You could have taken it before then, and you could typically take it usually by June of the year that you're applying as well to still be okay. But that's typically your MCAT time. At this point, I want you to make sure that you've requested your letters of recommendation. This is the biggest pain in the ass, right? Professors are annoying. They disappear. You ask them for letters. They never come back. You email them. They ignore you. Start requesting your letters as early as possible. In May, June, if you haven't taken the MCAT, you got to take your MCAT for that given year. You want to complete your AMCAS application, and for you guys, TMDSAS, right, the Texas application as well. It's very similar to the AMCAS application. It's got a couple extra essays, but in general, you just sit down and do one application, and you'll be able to use most of it for another application. You want to get submitted. July, August, secondary applications. Another pain in the butt component of med school applications where they're going to ask you all the same questions you just did for your primary. They're going to ask you again for the secondary, and they're going to expect you to write something different. So on the primary application, they say, what are your most important activities? And then the secondary application, they say, tell me about your most important activity, but don't tell me what you told me about the AMCAS. And you're like, how many important activities can I have? You'll have to figure it out. It's a pain, but if you plan early, you can do it. And then September through April, interviews, follow-up, update letters, and then hopefully an acceptance and into medical school, right? Remember, only 40% are going to get in, and so the earlier you start planning, the better you're going to have at putting a great application together. Well, so everything I just talked about was all about sort of proactive planning, right? And you guys are already doing this. For the freshmen in the room, sophomores in the room, that's great. You guys are here early. You guys are thinking about this early. You guys are getting skills early to put on your resume. All good things. The earlier you think about it, the better you're going to actually end up being. For people who think about it too late or don't plan and prepare, that's when problems come in. I mean, I tell the same thing to my fellows who I train in interventional procedures, right? We have a big back table, right? It's a sterile back table, It's got the needles, it's got the wires, it's got the catheters, it's got everything that we need, the stents, whatever else. And the worst fellows have no idea what's coming next, right? And so they don't have their syringes ready. They don't know what wire we're going to use next. Their table is a giant mess. If you have prepared that ahead of time, your procedure is going to go super successfully. If you know exactly your steps that you're going to take, your procedure is going to go successfully. Even if you have a road bump, even if you dissect out an artery, let's say, or you cause a bleed, or you spasm something down, as long as you know and are prepared ahead of time, you can deal with that. And that's the same thing in the med school application process, right? There's going to be that dissected out artery, which might be a bad score on your midterm in orgo. But if you've planned it out, or you have the ability to sort of, if you've laid things out and know where you're going, you can make those changes along the way and still be okay. For those of you guys who are applying, personal statement, incredibly important, right? Becoming more important, again, particularly as you put less emphasis, hopefully, on grades and GPA. Interesting introduction, I think, is the most important thing. Take your time with this. Really get it edited, really get it looked at, because that introduction makes or breaks. Got a stack of applications this big. I mean, I used to review applications when they were still printed out, by the way. Now, of course, they're all digital. But stack of applications, either online or in paper format. I am looking for any reason possible to put it in the reject pile, because I only have X amount of interview slots to give. And if your introduction to your personal statement is boring, I'm not reading the other 5,300 characters. I'm tossing that into the reject pile. So take your time to really make sure that that is what you want it to be. Let me give you some examples. These are personal statements that I may actually want to keep reading, right? There are a ton of personal statements. I can tell you that I read the first couple of sentences. I don't want to keep reading. So it doesn't have to be Shakespeare, but it should be interesting, right? It should capture that reader's attention. Super, super, super important. This might be helpful for those of you guys who are applying this year, so I put it up here, particularly obviously for those of you guys who are applying out of Texas, but also for those of you guys who are applying in Texas. This takes you through every single thing that you need to do on the AMCAS, how to fill it out, what each individual box may mean. It can be more confusing than not, so if you need that, just go ahead and download this, and you'll have sort of a guide through the whole thing. Now, let me sort of end with a couple of thoughts, right? I started with, hey, medicine is super cool, and I'll end with, hey, medicine is super cool. Everything I just talked about and all the things that you have to do are going to be worth it. There's no career that truly is like this, right? I mean, think about the trust that a patient puts in you. Yes, put me to sleep, cut me open, do what you got to do, and sew me back up. Like, I mean, that's what people say, right? There's no other career do you have that trust of another human in the way that you do in medicine. And then you also have a responsibility like no other. Has anybody listened to the Dr. Death podcast? Podcast series called Dr. Death, which you guys should listen to for a perspective that's very different, right? It's actually a podcast that's talking about this guy. He was in Texas, actually. I think he was in Plano, Texas. He's a spine surgeon who essentially mauled people. Patients would come in with L4, L5 disc pain. They would have herniations or sciatica or whatever else. They would trust him, sign him up, get signed in for surgery. And he killed many of these patients. And this is not a long time ago. This is like recent. This is a couple of years ago. I mean, think about that responsibility that you have as a physician, that you literally could kill anybody that you talk to or that you touch or that you are a part of. That patient is putting so much trust in you, right? There's no other profession that gets you that amount of trust, right? And it's not something that anybody in this room should take lightly at any juncture. And I really say it's an everyday like no other, right? Every single day is different. Every single procedure, every single patient, every single thing that you come across is really different. You can make a huge impact, right? Again, it's not for the money. It's not for the ease of life, because these are very hard things in medicine. But at the end of the day, you would come home. I share this anecdote. I had a really great family member who was a consultant, and this was back when I was a pre-med, and I was talking to her, and I was trying to decide what I was going to do. I was an engineer. I wasn't sold on a career in medicine, and she was talking about her marketing career. And she was super excited by it. And she's talked about how exciting it is, like on an everyday basis, that she gets to market for these products. And I said, okay, what are you marketing for? Men's deodorant. And so at the end of the day, her job was to sell more men's deodorant than some other company. And I thought about that and I said, that's not exciting to me. Like, I don't want to come home and be like, I sold more Old Spice than Dove or whatever else, right? Like, that wasn't exciting to me. And so as much of a pain as it was to go through the process of becoming a physician, I think it's well worth it at the end of the day. Now, just a quick note about MedSchoolCoach. I gave you a few of the resources from the MCAT side that we have that I think are really good. For those of you guys who are going through the process or early in the process and want some guidance, mentorship, coaching, whatever else through it, that's what we do. And we help people essentially get there, right? So we have physicians like myself and others who've sat on admissions committees, know what it takes, can help you figure out how to put together a great application, can help you put together a great essay, help you edit that essay, interview well, all the things that you're going to need. Any leg up that you can get is probably good. And so if you want to sort of book any of the meetings with our enrollment team, you can just scan that. There's a bunch of other things that you can scan around the room as well. It will be super helpful for you, I can promise you, in putting together a great application at the end of the day. All right, so that was my talk about being a pre-med and a few of the things that you guys have to do, hopefully. Let me stop here for a sec. I know we have a bunch of other talks to listen to. Questions, comments, concerns, ideas? I'm also, of course, happy to talk to everybody individually. Yeah?
So when considering like on med school applications, like clinical experience, what would you say like the difference between like having volunteer work versus like paid clinical experience? Like should you have like a little bit of both? Like is one more important than the other? Like what are your thoughts?
Great question. So the money, the payment doesn't matter, right? So there's a bunch of categories that you can select on the application. Some of them are going to be paid, some of them are going to be unpaid, some of them are going to be volunteer, some of them are going to be clinical. The categorization is actually less important. What is actually more important is your portrayal of such, right? And so whether it's paid or unpaid, whether it's volunteer or something else, what I care about is not the title of it. What I care about is the experience you had, right? So if you were a paid EMT, fantastic. But if you're a volunteer EMT doing the same thing, fantastic as well, right? It doesn't really matter. What I care about is that, hey, did you actually take the vital signs of that patient? Did you take the H&P? Were you out on the ambulance run, right? Those are the more important things. And so I would not worry about looking for an experience necessarily that's paid versus unpaid. I would just look for the experience itself. Obviously, if you can make some money out of it, fantastic, but that's not the really important thing. It's all about that paragraph that's what you got out of it or who you interacted with. Good question. Other questions? Yeah.
Is there any specific leadership experience that the people going over the applications would be looking for? Like, I guess I would be comparing like being an officer in an org compared to being like a TA or something like that.
Both great experiences, right? Again, it's all about how you sort of are going to portray that, right? So it's not a checkbox of has this person started an organization, but it's does this person embody some leadership, right? And if you're in front of a room as a TA, that absolutely is leadership experience, right? And so it's all about going to be how you write about it on your application. Don't think of it as what is better, X or Y. Think of it more about what am I getting out of each of these experiences, and then how can I craft that into the theme of my application. If you're a TA, that's fantastic. If you're part of a organizational e-board, also fantastic. If you've started something, maybe even better. And now, if you've started something that is in line with the rest of your application, even better, right? What do I mean by that? Well, I did a bunch of TAing, for instance, when I was an undergrad. I also did a bunch of summer teaching experiences. I also started a volunteer tutor organization in undergrad, right? So now you can see that like my application was very much crafted around teaching basically teaching was a big part of my application, right? So that was why the TA experiences were powerful there. Conversely, if let's say you're a computer guy or gal, and you really want to start an app that, I'm making this up, but collects data for blood sugar levels on diabetic patients in an underprivileged population. Well, do that and talk about your computer experience and talk about the fact that this is what you started. Now we're talking about crafting an application that's sort of cohesive and has a central point. For that person, TAing might be less important, right? Or might be something that they not look at negatively by any means whatsoever, but doesn't sort of go with the rest of the brand that you're trying to create for yourself. So all these experiences can be great. They're all good. To take another level up on them, think about how they can go with the rest of your application, because that's what you're going to sell in your personal statement, on your interviews, and anything else. Answer the question? Yeah.
So when you're crafting your theme for your application, it can be kind of difficult to connect all of your activities and everything to your theme. Would you recommend trying to connect everything, or just have different parts of your background go to different parts of your application?
So don't stretch the connection, right? Which I've seen people do, right? They try to connect every single part together, and sometimes you can see through that, and it becomes worse, right? Not every single person is going to have one centralized thing that they are, that is the thing that they do. In fact, most of you guys, and most of you guys should, you guys are in college, you guys are young, you should explore all kinds of different things. Now, if you can craft a bucket of things to a centralized theme, great, do that. But leave the other things aside or talk about them, but you don't have to always connect them back to the main, maybe theme, or the main thing that you think sets you apart or makes you unique on your application. Yeah. Say that again? A BSA versus a BS. So I don't even know what a BSA is. A BA? It's a Bachelor of Science. Got it. So maybe my answer to that question is exactly what I just said. I don't even know the difference, and I've reviewed a lot of applications in my life. The reality is your major and your BA, BSA, BS, double major, et cetera, make relatively little impact to no impact. What makes the impact is the overall GPA at the end of the day. Now, if you could talk about, hey, I was double major and this is why I was double major, might be interesting. But the reality is, on like a screening process or anything else, it's just that total GPA number that makes any difference. And so this is actually an important distinction. If you guys are thinking about, hey, what do I want to major in? I would think about it in a way that's like, hey, what am I most interested in that's going to get me the highest GPA possible, right? That's what's most important, not what's going to look good to medical schools. Because a bioengineering major with a 3.3 GPA is always going to do worse than a religion major with a 4.0 GPA. It's just the way it is, right? So that GPA, try to get that as high as possible, regardless of major, regardless of what the degree ends up being. Yeah.
I've heard talk of like a science GPA versus your total GPA. Is that how real is that, and how important is the?
Sure. So AMCAS, which is the centralized application system for non-Texas MD schools, has what's called the science GPA, a non-science GPA, and a total GPA. The science GPA is often referred to as the BCPM GPA, biology, chemistry, physics, and math. Those are the classes that go into the science GPA, right? And then there's the all others, which go into all others, and then there's a total, which obviously is your total. So what's most important? Well, all three of these things are listed out on the AMCAS. In fact, if you look back at some of the slides I presented earlier, and remember I showed you the average and the average matriculant and average acceptance student, they actually had all three of these different things broken out. In fact, I'll go back to that to just reference it. So what's most important? Well, each of these carries weight, right, for sure. Let me try to find that slide. There you go. So GPA science, GPA non-science, GPA total. Each of these carries weight. Obviously, most people's non-science GPA is going to be higher than their science GPA. And you can see that in the matriculated numbers too, right? The average matriculated non-science GPA 3.84, average science GPA 3.68, and average total 3.75, right? So what's more important? Well, if I had to like put an emphasis on something, I would say the science GPA, for rather obvious reasons, is probably more important. But most people don't have huge disparate discrepancies, right? It's not like people, I don't see many applicants with a 4.0 science GPA and a 2.0 non-science GPA, or even vice versa. Most applicants, you know, if you're getting A's in most of your classes, you are. If you're getting B+ in most classes, that's sort of where you are, with maybe a little bit lower in your science side than your non-science side. That's why I went back to saying, hey, you know, if you're a religion major, you might have a higher GPA than a bioengineering major just because of the nature of the classes. As I look at application, all these are important. Science GPA maybe takes a little bit more precedent. As you guys are thinking about how you're filling out your application, think about the courses that you might be taking that are sort of quasi-borderline, and maybe if you had an A in them, put them towards your science GPA, if that's lower, right? What's a quasi-borderline course? The statistics of biology, right? I don't know what courses are offered here, but I'm making that up, right? One of these courses that like might be, hey, that could go either way. That might be a or epidemiology of, you know, public health. Well, that could kind of go either way. The AMCAS actually, in that AMCAS guide I sent, has a rule book of where you should follow, but the reality is you can sort of cheat those rules a little bit and skirt sometimes towards the science side, as long as you could back it up and say, hey, there were a lot of, this was basically a science-based class. And the interesting thing is, if you've misclassified it, nobody cares. It doesn't affect your application at all. So that's a little thing to think about as you're putting together your application. Other questions?
This is more about interventional radiology. Out of curiosity, so I saw the picture earlier that you presented, right? You're injecting the needle down, knowing that which part of the body is it going to. So like a symbol, a phlebotomist, you know whenever you hit the vein, right? You feel it. So do you feel it when you hit the liver?
That's a great question. So the more you do, the more you can get a feel, right? So I can feel it a whole lot better than my fellows can feel it. That said, it's not the same. There are some things where it's very feel-oriented, right? So I know exactly how my wire is supposed to go, and if I'm tracking my catheter over, if my catheter is not moving in a one-to-one relationship to my wire, I can feel that, hey, this is not going exactly the way I want it to. So some of that is feel. In that TIPS procedure, it's actually less about feel, because actually the only thing you feel in a TIPS when you do it sometimes is a really rock-hard liver, right? I mean, these livers are hard, right? These cirrhotic patients, their livers have had years of abuse, and it's like essentially sticking a needle, like, you know, imagine sticking a needle into this ball versus sticking a needle into this desk. And what the difference is, that's the difference between a soft liver and a cirrhotic liver. And so actually what you're doing is you're actually looking more for you're sticking in a trajectory where you know it is, anterior, and sometimes medial, sometimes lateral, depending on where you're sticking from. And then you inject these small amounts of contrast dye to see where you ended up. Maybe I ended up in an artery, no good. Okay, I ended up in the portal vein, and I know what that's supposed to look like because, you know, done hundreds of these, so you can understand exactly what you're supposed to see, and then you thread the wire. So it's a combination. So IR is a lot of feel, but sometimes it's visual, and you have to see what you're looking at. Similar to a phlebotomist, right? You might stick the vein, but if you don't see the flash of blood, you might not be in. So we're looking for that similar flash of blood in that TIPS procedure. Yeah.
Is your like end of college GPA the same GPA you would apply to med school as? For example, like because I have like different classes where like the grade cutoffs are like a 94 or like a 90. So it's like if I would get a 93 in a class, that wouldn't actually be an A. But so like whenever I go to apply to med school, would that GPA change at all?
So yeah, your GPA at an individual institution is normalized on the AMCAS application, right? So it's normalized across the board depending on where you ended up. So I apologize, I don't know what the grading system is here or what you end up with, but essentially it has to be the same as everybody, somebody coming from UT Southwestern, NYU, or anywhere else. And so they normalize it across the board. So it will have some variation compared to where you are, right? There are some schools that don't have A pluses, so everything ends up as an A, regardless of how many A pluses you have. So your GPA, if you guys have A pluses, your GPA might be a lot higher here than on your AMCAS because everything gets normalized down to an A. So across the board, across the country, everybody's playing on the same playing field. And it also counts, AMCAS also will take into account any classes that you've taken over the summer at maybe another institution, right? So your final UT Southwestern, sorry, not UT Southwestern, UT Austin GPA may not account for that because you may not transfer those credits, but AMCAS will. Or you might do a postbac, and those classes will then count towards your GPA as well. Any other questions? I got to check what time it is. How are we doing on time? Oh, 12:30, not bad. Other questions? Yeah, last one.
What are your thoughts on tips for applying, like during like the junior year admission cycle, and then deferring your admission for a year versus waiting until your senior year to apply and taking a gap year that way?
So, in general, the more time you have, hopefully the better your application becomes, because you get to do more activities, you get to maybe get a higher GPA, you get to have more leadership, and so if you're only applying to defer, I would want to make sure that your application is really stellar, first off, because if it's not, then you could take that year to improve it, right? And then if you're really going to defer, you got to have a really good reason for the medical school to allow that deferral, right? So you can't be like, I'm going to Cancun. You have to say something like, hey, I'm going to do Teach for America for a year or something along those lines, which actually, by the way, when I applied to med school, that was exactly what I did, which was I was going to, I applied my junior year, I got in, and then I actually said, hey, I'm thinking about deferring. And I was going to do, I didn't end up deferring, but the schools were all cool with it because I was going to do Teach for America for 2 years in between. And so they were okay with it, but I had to have a good reason to do it. I don't want to see somebody just apply and defer for the hell of it, because you could probably do a better job improving your application over that year anyway. And so take that time to improve your application as best you can. Great. Well, hopefully this was helpful. I think we got a lot more in store, right? We got the suture clinic. Madison's going to talk a little about GMB as well. I will come back at the end of the day to talk to you about a little bit more just about medicine, right? This is all about pre-med. I want to talk to you guys about medicine. Hopefully that'll be an interesting talk for you guys. I'm also around all day, happy to talk to everybody individually. Just come up and find me. But we'll move on to the next part of the talk here. Thanks, guys.